So we've got our patient here, John. He's a 56-year-old bus driver who has hypertension. He's on the GP register as having hypertension, but his blood pressure was poorly controlled when it was last measured, with a BP of 162/98 in the clinic setting. He smokes cigarettes. He's prescribed amlodipine 10 milligram daily for the past 2 years. He's not on a statin. And running those priority groups, those searches, he would be flagged up as priority group 2 on the basis of his blood pressure. But even if his blood pressure was a little bit lower, he would probably fall into that group because of his ethnicity. So next slide, please. So he's one of our higher priority patients. So from John's perspective, we need to think, well, what can we monitor and manage for him remotely? What lifestyle advice and behavioural change do we need to support? Obviously, does he need additional drug therapy because his blood pressure is poorly controlled? And are there any other issues we need to address? So our starting point might be hypertension. But clearly a patient like this who's got hypertension, who's at risk of cardiovascular events, we also need to assess that cardiovascular risk. Think not just about lifestyle, but other things like lipid management for him. So next slide, please. So the first step might be using someone in the wider workforce, like a HCA, to use who could use a phone call or a video consultation to contact the patient and do some very basic stuff around asking about his understanding of blood pressure and cholesterol, signposting him to relevant information through the British Heart Foundation and other websites, sharing videos. So first they might check that he had a blood pressure machine at home. We know that 30 to 40% of people do have blood pressure machines at home, and it tends to be a higher rate people of Black African and Caribbean and South Asian ethnicity. So he may well have a blood pressure at home, and if he does a machine at home, and if he does, then he needs to know how to use it properly and advise him how he might submit the results into the practice, for example, using the AccuRx Florey for blood pressure monitoring. That might sound like gibberish to people who aren't used to the GPIT systems, but it's a sort of automated text-based way of getting readings into the system. They could ask about his smoking, see if he's ready to quit, signpost him to OneU website and the personal quit plans, and also to any local stop smoking services that might be available, whether that's internally in the practice or offered through community pharmacy or other services. We should be checking people's mental health, seeing how they've coped. Obviously, we've had a big period of lockdown, signposting to the Everymind website for tips on mental well-being, and then collating all the information the clinician might need to go further on with a consultation about managing his blood pressure medically. So next slide, please. The sorts of information the HCA should be looking at is the home blood pressure readings, if he can submit them. So his average was 162/91, his BMI, because weight is obviously going to increase his risk if he's overweight. His blood results, thinking particularly of his cholesterol, so total cholesterol, HDL and non-HDL cholesterol, his smoking status, his Q-risk score, which is based on much of this data, which comes out as 17.5%, and also worth noting from the patient record whether he's actually been picking up his medicines, because that's a really rich source of identifying non-adherence. So he has been picking up his medicines over the past 9 months. Doesn't mean he's taking them, but he's picked them up regularly, which is a good starting point. So then the prescriber would see this patient, review the readings and the blood pressure, highlight some of the issues that will already have been touched on by the HCA. Really important that we do focus our minds on behaviour change and reinforce those messages. See if he's got any concerns or side effects with his medicine, and if he's taking it regularly, and if there are adherence issues, make sure we explore those. Check on the complications and comorbidities if there are any. Obviously, he would need his blood pressure medication adjusted because his blood pressure is currently poorly controlled. And think about this point, would start to have that conversation about cholesterol. No point in managing one cardiovascular risk factor and ignoring the other. So need to think about statins based on his Q-risk score. It might be that he wants to take information away, have a look at the website, have a discussion with his family before making that decision, but we need to make sure it's then followed up. So next slide, please. And I think this is the follow-up. Again, doesn't need to be face-to-face at this point. You might need to get bloods, but again, that can be done not at the, it doesn't need to be done at the same time as the appointment. In fact, it won't work if it's the same time as the appointment usually. Follow up on the lifestyle again. Keep addressing concerns or issues with the medicine, particularly the new medicine, titrate the blood pressure, and then revisit the statins and initiate at over 20 with a shared decision making with the patient. That's a very brief overview of how you might approach a patient to make sure you're addressing all of their cardiovascular risks. We're focusing on blood pressure and cholesterol, but all of the lifestyle stuff equally needs to be addressed alongside that.